Hello, welcome to Health Alert. I'm Pam Butler. Today we're going to talk about women and heart disease, and joining me is Dr. Charles Foulks. He's a nephrologist with OU Physicians in Tulsa, and he's also the chair of internal medicine. Welcome to the show.
Hi, Pam. Thank you very much. Pleasure to be here today.
Now, before we begin, tell us a little bit about nephrology and being a nephrologist. What does that encompass?
Okay. Nephrologists care for patients who have diseases of the kidneys that can be treated medically. We take care of patients who have kidney damage because of diabetes or high blood pressure, certain inherited diseases. As you have alterations in your kidney function, the kidneys are not able to keep all the chemicals in your blood in the proper balance that they should. So we deal with all of those sorts of things as well. We do not do surgery. We're not urologists. If you have problems urinating and you have a big prostate, we're not the people to come to.
Okay.
But for diseases of the kidney that are damaged by a variety of things, we are people with difficult to control high blood pressure, CS. We're the experts in that particular area. We take care of patients who have kidney transplants, patients who have problems with their kidneys because of other disease processes, patients who have problems in the hospital because of reactions of the kidney to certain drugs and damage by those drugs, and as well take care of patients who have acute kidney failure in the hospital. And we now call that acute kidney injury is the current name for it. It's the old acute renal failure that most people would be familiar with. And this is the acute kidney injury that you see from people who have had massive trauma, burns, overwhelming infection, shock syndrome for a variety of reasons, and we care for those people. So we do not only that, but we also care for all the patients who are on dialysis, and so we in effect act as general internists for those patients. It is typical for the nephrologist to deliver not just the dialysis care, but also the care for their high blood pressure, if they've got heart disease, if they've got lung disease, if they have arthritis. We do the general internal medicine management for those patients as well.
Now let me ask this question because, you know, we see a lot of the ads on TV that talk about different medications and ask your doctor. And sometimes by the time they get through telling you the side effects, sometimes personally I wonder why would I even ask. However,
I've thought about that myself.
But a lot of times you hear them talk about involvement of the kidney or this or this. So if people are on certain medications that could possibly have that effect, do they come to a nephrologist first, or do they go to a primary doctor and only to be followed, and only if there becomes damage then you step in?
Well, when we see those reactions to those kinds of medications, and the non-steroidal anti-inflammatory drugs are the biggest ones that do this. These are the medications like ibuprofen, Motrin, Naproxen, Aleve. Those things are constantly being advertised on TV. People who have difficulty with their kidneys from that generally have it picked up by their primary care physician, or it's picked up in a minor clinic where they've gotten blood work for some reason, or they actually can be sick enough to come into the hospital and it's caught there. So we're not the ones who initially catch it, but we're the ones who diagnose it and ended up caring for the patients. And you know, sort of one of the common sayings in my field is that as long as there are drugs, nephrologists will never go out of business.
Yes.
Because most of these drugs have side effects of either the liver or the kidney. A large number of drugs are excreted or metabolized by the kidneys, and you just need to be really careful out there about that stuff you take.
And especially the over-the-counters, because a lot of times we self-medicate, and sometimes we think, well, if 2 is good, maybe the bottle is recommending 2. You know where I'm going with this.
Yes.
The bottle is recommending 2. Well, 4's got to be better to really wipe that out right away.
Yeah,
but we really need to pay attention to those directions.
You absolutely must pay attention to those directions. It is very easy to get into trouble with those larger doses. Many of these drugs that used to be prescription only that are now over the counter, those doses that they have on the bottles are the lower doses, and they're the ones that you rarely see problems from. Occasionally you will, but not usually. It's when you decide to double or triple that dose, that's where you begin to see the side effects from those medications. So the FDA has been very careful in their labeling on that. So if you'll follow the directions on the label, the odds that you'll get into trouble are pretty darn small. But if you try to increase it, then you're just increasing your risk from that particular medication. Probably the biggest culprit that we see is really acetaminophen.
Really?
Yes. People, one, don't recognize how many medications have acetaminophen in it.
Right.
And they think, well, this is an innocuous medication. This is what they tell us to take to give our kids, so it must be safe, so I'll take some extra. Well, the problem with acetaminophen is it's acute liver damage, and there is no warning that that's happening. And it's very easy to stray over and begin to take toxic doses of acetaminophen and come in with liver failure from that and die. And I've seen people die from this. I remember a young 22-year-old girl when I was in San Antonio, and she was taking acetaminophen. She was also taking another medicine that had acetaminophen in it, and so she decided to really up her acetaminophen dose, and she came in with fulminant hepatic failure, and she died. 4 days later, she went to the morgue from the intensive care unit. So these disorders are very scary, and it's very easy to get into them. Something else that other people need to recognize is that as we age, the ability of our liver to metabolize those medications like it used to when you were 20, that ability just isn't there. And older patients can be really sensitive to the effects of those medications.
And that's really important too to remember, and especially even with not just doubling the dose and paying attention to, are you getting additional doses in other medications too, and talking with your doctor about what you should be doing, but also the length of time, because it often will tell you, take this no more than, excuse me, for this length of time, and if you have trouble or it hasn't gone away, contact your physician, stop the drug. Don't just keep thinking, oh, one more series will be okay.
Yeah, you're absolutely correct on that. Those time lines that we have on the recommendations for those drugs, the over-the-counters like that, again, those timelines were chosen by the FDA because over that short period of time with that particular dose, the odds you're going to have trouble are small. But if you extend either the dose or the timeline or another course of the medication, as you said, you're beginning to play with fire.
Okay, and those are things we need to definitely keep in mind.
Absolutely, and when you're getting to that point and you've got something that's really bothering you and your first course on the label of the bottle hasn't done anything, you need to call your doctor, because you're going to start monkeying around with medication side effects that you don't want to deal with.
Now tell me a little bit about, and we will swing into our issue of looking into women heart disease, but I want to get the things out about the drugs. For people, we take all different kinds of even prescriptive medications, and then sometimes we'll go and add an over-the-counter. Let's say the high blood pressure, because like you're saying, that can cause kidney damage and that. So we're taking a medication for high blood pressure. And then we go and we take maybe an allergy pill or something that if you read the label, it says you shouldn't take it if you have high blood pressure. There are other options out there. What are we potentially doing when we do that?
Well, what you do is you counteract the effect of the high blood pressure medication, and you can make your blood pressure really very much worse. The medications that you're talking about, the antihistamines, are generally pretty safe in patients with high blood pressure. It's the combination medications that get you into trouble. The Dimetap, where there's a vasoconstricting drug in there. The medications that have ephedrine, pseudoephedrine in them, such as Sudafed and Actifed. Those particular drugs, the pseudoephedrine, causes the blood vessels to constrict, which will increase your blood pressure. And this can be very dangerous in somebody, especially if they're on multiple medications for high blood pressure, they have severe high blood pressure, or they have heart disease, or they've had a prior stroke or a TIA, or they have kidney problems. Those medications can be extraordinarily dangerous. I don't recommend any of those to my patients. I don't use them in our household. The most I will generally recommend will be a little chlortrimeton or Benadryl over the counter. They're generally pretty safe. Claritin, plain Claritin seems to be fine. Plain Allegra seems to be okay. But you get into those combinations and you really need to be careful.
We're going to take a really quick break and come back and pick up on our heart disease issue.
That sounds great.
Please stay with us. We'll be right back.
Up to 40% of businesses never recover after experiencing a major disaster. Make a plan at ready.gov/business.
Welcome back to continue our discussion talking about women and heart disease. Joining me again is Dr. Charles Foulks. He's the chair of internal medicine at OU Physicians in Tulsa. Let's jump in.
Great.
Now, we talked a lot about the drugs and
Yes.
the perspective of the kidney and nephrology and that, which is really important for people to know. Tell me a little bit about, just sort of start with an umbrella picture of heart disease. And we're going to focus on women, but if you want to sort of in general talk about heart disease, whether it's male or female, and then we narrow it, but tell us about what's happening with heart disease.
Well, most people, when you mention the phrase heart disease, are really talking about what we call ischemic heart disease, or heart disease where there's an impairment of blood flow to the muscle of the heart such that you either have a heart attack, as we classically know those, or the heart becomes starved for blood very slowly and the heart muscle very, very slowly dies over time. That particular one is unusual, is more commonly seen in diabetics, and is due to very small blood vessel disease in the tiny blood vessels that give the blood to the heart. But when you're talking about the ischemic heart disease, the one where you have a heart attack, the risk factors for that in this country are diabetes, hypertension, smoking, obesity, and actually sedentary activity. Those are the major risk factors, and your family history. If you had a female member of your family who has had a heart attack or a stroke or has had a problem with the blockage of an artery somewhere else before age 55, you are at high risk of having a heart attack or a stroke yourself.
Really?
If you have had a male member in your family, well, actually I said 55, that's actually for men. For women, it's under age 65.
Okay.
Women are, we believe, are naturally protected by the fact that they have periods and they make estrogens. When you go through menopause, that natural protection seems to go away. We used to believe that if you put people on supplemental, women on supplemental estrogen at the time of menopause, you could prevent heart disease. That is not true. The studies are very clear about that.
Okay.
And so it's still, why there's a sex difference in this, we don't really know why that is. We do know that the same triggers are there, though, and one of the things that really is a very important factor in heart disease in women is the fact that they're exposed to secondhand smoke. If they smoke themselves, that's awful. But remember that that secondhand smoke in your home from your husband or whoever else it is smoking in your home is putting you at risk of heart disease and lung disease as well. And it's almost as bad as if you were primarily smoking. So the smoking is an absolute major risk factor that you need to make go away.
Now let me ask this too, because even with the secondhand smoke, because I've done programs before where people have even clarified in the clothing, because they were saying that, you know, you really need to, if you're in an environment with a smoker or they live at your house, they should smoke outside and even get rid of the clothes, and because you really are breathing from the clothing as well.
That is correct. You're carrying all of that stuff in with you. And what you just said is really very, very, very true. Even being exposed to secondhand smoke in the workplace is a very major risk factor as well. When we see people who are exposed to secondhand smoke, they have trouble believing that this really has caused their problem because they've become so used to it. It's sort of like the smoker who quits smoking and a month later goes, ew, you smoke, you stink. They can suddenly tell it because they're not living it every day to day. Well, when you're in the secondhand smoke every day, it becomes a part of your environment and you don't notice it anymore. We also know that that causes a lot of problems in children. It's a cause of recurrent ear infections, a cause of asthma, a cause of bronchitis. You know, smoking is just really terrible for everyone's health.
Now let me ask this question too, because you talked about after menopause how the natural protection for women goes away. Does heart disease then start to mirror what it looks like in men, because they don't have that natural protection the same kind of way?
In terms of the percentages of heart disease, yes, it does. They catch up to men. It takes about 10 years, and then they will catch up to the rate that men have. The thing that is really bothersome about ischemic heart disease in women is it does not follow the classic presentation we see in men. In men, you're used to the crushing pain. An elephant's on my chest, they'll make a fist. It's someone standing on my chest with this awful ache. It's gone to my jaw or my shoulder, or it's in my elbow. The presentation in men is typically very classic. That is not hard to figure out. Women, not like that at all. That is not the usual presentation. The presentation in women can be complaints from anywhere in the abdomen on up to here of, I just don't feel well. I'm a little woozy today. I'm not thinking as clearly. Well, you know, I had a little shortness of breath when I, you know, lifted the garbage out of the garbage bag. Or, you know, I have this kind of funny numbness in my elbow, but I just don't feel good. When you begin to hear those complaints in women who are over age 50, you had better pay attention to that. And if they have had diabetes or high blood pressure for 10 years or so, you better pay attention to them no matter what their age is. I have seen women with heart attacks in their late 20s who have had diabetes and hypertension for 15 years. And you would say, 28-year-old women don't get heart attacks. Well, yes, they do if they have the proper risk factors. And the reason it gets missed in women is the presentation is so atypical. So what I tell our medical students and medical residents is when a woman who has exposure to risk factors or is over a certain age begins to tell you about these funny complaints, don't forget this as a presentation of ischemic heart disease. You have to pay attention to it. You have to think about it. If you don't think about it, you won't look for it. Now, does that mean that everybody who comes in, you know, who says, oh, my elbow is numb, is I'm going to put them through a cardiac workup? No, it doesn't mean that. What it does mean is I'm really going to start poking at their history, trying to flesh out a little clearer what the history is, what might have precipitated it, how long did it last, what made it go away, does it recur? If you get elbow numbness and you get it every time you take the trash out, and you get it when you carry groceries in, I'm going to get really worried. Well, it could be related to the weight, but it could also be related to your exertion. So
how about that?
Yeah,
Right.
you went straight for the mechanical.
Which makes us miss it.
Which makes us miss it. That's happening. I didn't set you up for that, but thank
no,
you. That was a soft lob. That was great.
I tried to be supportive.
You did a great job. But no, it's the exertional component of it that you have to look for. And so you really have to ask a lot of questions about that. And women need to understand that when they go over about age 40 or 45, they need to start thinking about this. If they've had exposure to secondhand smoke, if they're overweight, if they're sedentary, if they've had diabetes for a while or high blood pressure for a long time, and they notice that every time they do something active, they just really don't feel good or they feel awful, it's a change for them, they need to let their doctor know about that. That could very easily be the first presentation of ischemic heart disease for them.
That's really good to know. And in our next segment, we're going to talk about, you know, sort of the test and other factors. But that's really good to know because sometimes we hear all too often, well, you're just getting older. You know, and it's almost like everything that happens, you're just getting older, so don't pay much attention to it. But what you're saying is, yes, we are getting older. Yes, we have greater risk in certain areas, but with these other risk factors, we still need to make sure we check that out with our physician, pay attention to it.
Absolutely. It is treatable. When I was in my internal medicine residency back in the 70s, it was unusual to have a patient over age 70 in the hospital. Folks didn't generally live that long, or if they did, they were in bad shape when they came in. I have patients in their 90s living at home independently, managing their affairs. Yeah, the kids have to drive them around or help them lift and do stuff, but they're taking care of their lives. If I don't pay attention at age 70, how can you get to 93?
Good point. Well, you stay put now.
I won't move.
And you stay put. We'll be right back.
Did you know that getting up and getting active for just 60 minutes a day is all it takes to help you get stronger, look better, and feel great?
Or that fresh fruits and veggies aren't just healthier and crunchier, they can taste better too?
Eating better and getting more active is easier than you think.
Yeah! Keep watching for some fun and easy ways to discover the magic of healthy living in your life.
America.
Let's get healthy together!
Welcome back to continue our discussion talking about women and heart disease. Joining me again is Dr. Charles Foulks. He's the chair of internal medicine at OU Physicians in Tulsa. Let's jump in. Okay. Now, and you're also a nephrologist, so I want to keep throwing that in there too. We want to get specific with women and heart disease in terms of looking at, okay, what do you do? Are there test factors? Are there enzymes we're excreting? I mean, tell me how are you going to tell?
Yeah. When I have someone come in who has, a woman who comes in who has what I believe are symptoms of ischemic heart disease, and it's not crescendo, in other words, it's not happening very frequently, it's not happening at rest. If you come in and tell me that as a woman, and I think it's ischemic heart disease, and you're having this at rest, you're going into the coronary care unit at the hospital, and we're going to take a close, long look at you. That's what we call crescendo angina, new onset angina. Angina is the term we use for the pain or discomfort you get with ischemic heart disease. So it depends on where you are. If, however, it's new onset, but you've only had it a couple of times, and it wasn't, well, every time I stand up I get it, well, that's not very much work. If you're getting that, you need to be in the hospital. If you say, well, you know, I usually go out and work in my garden, or my husband and I are used to a 2-hour walk every evening, but I'm noticing that if I go more than about, you know, the first hour or the first mile, I start to get this funny feeling, then I'm going to evaluate you with the stress test. Now, everybody's used to the stress test, the treadmill test. And the plain treadmill test is fine for men. For reasons that we do not understand, the plain treadmill test is the wrong test for a woman. It will have false negatives, and the person will really have underlying ischemic heart disease, and the test will miss it. So we have to do a special treadmill test then. It's called a treadmill thallium, or a nuclear medicine treadmill. And what you do is the woman still walks on the treadmill, and we look at the EKGs, but they get an injection of a radionuclide that's got thallium in it. And what will happen is if you have an ischemic area in the heart, the thallium will pick it up. And so after you finish the treadmill, you lie down on a bed, and they put the camera over and take pictures of your heart. And that's the preferred test that we would use for women. And then we would go from there to decide whether or not you would need heart catheterization. The real reason that heart catheterization is so important is if you have what we call left main coronary artery disease, or left main equivalent. When you think about the blood that goes to the heart, you have to think about what part of the heart is the biggest muscle, and it's the left ventricle. That's the part of the heart that gives blood to your whole body.
That's pumping. There
is a major blood vessel that feeds the entire left ventricle, and it's also got a couple of branch blood vessels. If there is a constricting blockage in that main blood vessel, we need to know, because if that one occludes or ruptures, you're either dead or you're going to lose a huge amount of heart muscle. You can also have the equivalent of that by having a blockage a little further down in the main one, but blockages over here in these branches that go about. If I block all the branches, that's the same as if I block the whole thing up here close. So again, that one can do the same thing. There's a high risk of dying with a heart attack with that, and if you do have that kind of heart attack, it typically will kill a lot of muscle.
Now let me ask this, because you talked about heart catheterization, that's why it's important. Just explain for us briefly, for people who are wondering, what is a heart cath? What do you do? What you
do with the heart catheterization is, you know, the big arteries that we have down in our groin, you can feel these very easily. The doctors put a sheath, a needle in, and then they put a wire in, and then they put a special sheath over that and take the wire out. And that sheath gives them access to the aorta. And then what they do is they take a catheter and run it up through there, through the aorta, all the way through the arch to the heart. Now remember that the arteries that feed the heart come out at the very beginning of the aorta. And so the tip of the catheter has to go all the way down to where the aorta joins the heart, and then they pump in dye under pressure. And it shows you the anatomy of those blood vessels and tells you what's going on. Now we have there are some non-invasive ways to look for people who have heart disease. If you noticed, about a month ago, there was a big news report on NBC Evening News about the use of highly specific C-reactive protein. Highly specific C-reactive protein is a test that tells us if you have inflammation in your body. Well, it can be up for really any reason. If you have an impacted tooth, a sore throat, you've hurt your knee, you've got a fever, all of those things will make it elevated. But if you don't have any of those things and you're an adult, it is actually more predictive of your risk of a heart problem than the serum cholesterol is.
Really?
Yes. The only problem is that when you look at it and you look at everyone else's risk factors for it, the risk factors are really the important thing. It's not the C-reactive protein that's important. It's just a marker. It's telling us that something's going on. So if you're a diabetic and you're worried about heart disease, you don't need a C-reactive protein. You need to get your diabetes under control and keep it under control.
Okay.
You've got to get your blood pressure under control, keep it under control. You've got to lose the weight. You've got to exercise and get out of sedentary activity. You get those things spiffed up. You've got them buffed. Then you want to know what your risk is. Then at that point, the highly specific C-reactive protein becomes a reasonable thing to look at. Now, is it going to make me as a doctor send you for a catheterization? No, it's not going to do that. But is it going to make me really make sure that we've normalized all these things? Yes. And in fact, there's also some recent data showing that people who take multivitamins and have elevations in their B6 and vitamin C levels in the body, that's related to a lower highly specific CRP. The point is this is so interrelated that we don't know all of the things that cause it to be elevated. But it can be helpful. It can certainly be a big motivator. If you don't have your diabetes under control and I show you that you've got a high CRP, well, that may motivate you to get your diabetes under better control.
Let me ask you one quick question in about 5 seconds.
Got it.
For persons who don't have these risk factors, but they're starting to feel some of these things, should they have this C-reactive protein? Does that help them?
They need to see their doctor, a good history and physical examination, and if the doctor thinks that this could be underlying heart disease, you need to go for the testing that will make the diagnosis. If you want to get that to help you with prognostication, or to tell you what might happen in the future, how serious it is, it makes sense to do that.
Okay, thank you so much. I'll have to have you back because there's much more to talk about.
Sure.
Thank you so much.
You're quite welcome. No problem.
Well, that's our show. For Health Alert, I'm Pam Butler. I'd love to hear your questions or suggestions for future shows. Please write me at Health Alert USA, P.O. Box 50913, Tulsa, Oklahoma 74150, or if you're on the email trail, please email me at healthalertusa@gmail.com. And also visit me on YouTube at youtube.com/HealthAlertUSA. And remember, talk to your doctor. If you're just not feeling well, you've got some of these risk factors especially, get the help you need and get it quickly so that you'll be around for a long, long time. Take care.